Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Dr. Farzad Mostashari. He's co-founder and CEO at Aledade. Welcome, Farzad.
Thanks so much for having me.
Yeah, a longtime friend of the show. We reminisce all the way back to those meaningful use days, but we've come a long way since those early days. I mean, we're hit 20 years at Healthcare IT Today from our first blog post, which is insane. But anyway, for those who don't know you, which is probably no one in our audience, but tell us about yourself and Aledade.
Yeah, this is probably the sweet spot of my audience.
It's true.
So
They, they, they know you.
I was let's see, I spent 10 years at the New York City Health Department and led ultimately created the Primary Care Information Project, which was around at that time back in the early 2000s, bringing electronic health records to primary care as a tool for prevention and public health. And then I joined the administration, where I think most people on your audience got to know me, where I was in charge of programs and policy for the Office of the National Coordinator and then the U.S. National Coordinator for Health IT until about 2014, late 2013, where I went to Brookings for a little bit and then started Aledade now 11 years ago.
That's amazing. So for those that don't know Aledade, what would you describe what you're doing at Aledade?
Yeah, basically what what we're trying to do is make it so that it's more profitable to prevent a stroke than it is to treat a stroke, which is what we would all want, right? Out of healthcare is fewer strokes, not necessarily just better treatment of strokes. So we work with independent primary care docs. We're the largest network of independent primary care docs in the country.
It's interesting to think about, especially with our backgrounds in tech, right? And implementing electronic medical records and all those things. How much of value-based care would you say is a tech problem and how much is a policy problem?
I think my kind of frustration, as it were, when I stepped down from, the best job I ever wanted, right, as national coordinator, was that tech alone, we could get adoption, but we couldn't get actually truly meaningful use without the financial incentives to be
Mm,
aligned towards prevention. And that to me was the kind of aha that you tech can be an incredible enabler, but in the right context. And the context, and particularly the payment context, matters tremendously. And if you're in a fee-for-service context, then you're going to use the best technology in the world for coding.
mm,
All right. And rather than for prevention. But if your business model flips and you're all focused on keeping people healthy and out of the hospital, well, then tech can be an incredible enabler of that. And I think that holds true for any technology you can imagine, but certainly including digital health.
yeah. I mean, dive into that a bit more because obviously, Aledade has been focused on that prevention piece, like you talked about. But walk us through Aledade's technology philosophy. Like, how did you design your tech stack to actually be valuable for this value-based care environment, as opposed to just, like you said, optimized coding, right? Which is important to right in this current fee for service environment. But if we're going to shift, like, how do you approach that from a tech perspective, and how is that different than what's maybe been offered in the past?
Yeah, when we started, it wasn't clear at all to me that we were going to end up building all of our own software.
Mm,
I thought, oh, there are, you know, people out there who've built the software. And when I looked at it, it wasn't a workflow tool. They were they were kind of reporting tools, and it would be like kind of some warmed over Medicare Advantage software that would tell providers like, oh, your DME costs went from $2.46 to $3.82. And it's like, well, what do you want me to do? What's the action, you know?
yeah.
Um, and so what's the operating system? And we started small and we ended up building this full stack technology now, John, which is everything from an interoperability engine to a prediction engine to an actuarial engine, but most importantly, a workflow engine where if the job to be done is make sure the right people get seen, then it's a work list for a scheduler in the practice to start at the top of the list. And if you have empty slots next week, these are the people who should be prioritized to be seen. If you're a nurse whose job it is to follow up with patients after ER visits, and that's a job now, right? It's not necessarily That's not necessarily a job in a fee for service practice, but in a value-based care practice, that's a very necessary job. You open up the app, you open up the work list, and you see all your patients who've been in the ER or been discharged from the hospital. You don't need to know anything about ADT messaging, SIUs, or any of the rest of it. But what you need is a simple place to go that will prioritize the next best action.
That's interesting. I mean, because I hear from a lot of organizations that says we have so much tech, right? And in some ways they do. They've implemented, and I think that's even more so the case at the health system level versus kind of the ambulatory practice, which maybe is a little less so. But they have so much tech, but I think you're pointing out the tech doesn't support those capabilities. Are there some specific technical capabilities? You talked about a few of them, I think, that Aledade provides primary care organizations. They couldn't just access on their own or within their EHR, which is probably the main tech tool that most ambulatory organizations have.
Yeah, and look, I feel like 10 years of my life was trying to get EHRs to be the tools for population health with decision support and registry functions and quality measurement at the point of care and I would say largely that didn't succeed.
Mhm.
And blood pressure control after, adoption of electronic health records was about what blood pressure control was before the adoption of electronic health records. So that was the frustration for me is if you were going to build a software stack focused on prevention and better primary care and better care coordination, what would it look like?
Mhm.
And how do we complement um, the essentially the things that EHRs weren't good at? And so some of what we have done is one, build that 360-degree patient view from inside and outside the practice. Particularly nowadays when primary care is not the gatekeeper, there's a lot of care that happens outside of the practice. There's a lot of things that the doc doesn't know. When the doc sees a patient who walks in the door, like my mom, right, who's 86 and has congestive heart failure, does the doc know that she didn't fill her last prescription because my dad went to the pharmacy and it was $700 for the first fill? Is there a reason for the practice to pay Surescripts to uh, match up the outgoing order with the fill and to give an alert at the point of care that the patient hasn't filled that prescription? No, the answer is no. Maybe it's available if you push a button and you care to wade through, right? But it's not a clean, easy alert that says, hey, this patient with congestive heart failure didn't fill that prescription for the SGLT2. So that's one. Another is um, uh, when my mom, has an urgent, she has trouble breathing, and she calls up the practice. Do they have a workflow for fitting patients in? And saying, call us first before you go to the emergency room? Or do they push patients to the emergency room? And when they get discharged from the emergency room, is there a workflow in the primary care practice to know, even if the emergency room is in the same building as the primary care practice, oftentimes there's no workflow for saying, one of our patients, one of our flock was seen in the emergency room. And so that to me is the key question is there a concept of a flock of there's a group of human beings that you own, whether or not they called you, right? And that I think is a critical component of population health, having a sense of who is my attributed population and how am I to be responsible for them. And then look, there are things that go beyond the capacity of a primary care practice. When my mom was in the ER with having trouble breathing, they slid over a form to us and they said, oh, you got to fill out this form before we can transport her. Can you guess what that form was?
HIPAA release. I don't know.
Yeah, it was your end of life wishes
Mm,
in the emergency room.
yeah.
right? Like, please check a box. Do you want a feeding tube? Like, come on. That's not
Yeah.
the place,
The worst time to have those questions
worst time to
asked.
have those conversations. So we at Aledade uh, provide patients with up to 6 hours of conversation about their end of life wishes when they're not in the emergency room. And
Right.
patients and their families love it. It's got a plus 92 net promoter score. But figuring out how to get that warm handoff from primary care to these additional wraparound services, that's the other component that, again, EHRs don't really have a concept of any of that, right? Of whether it's identifying who are the patients who would benefit the most from this intervention, to the warm handoff to an external group, to the task interoperability and the data interoperability needed to do that. And we do it because it's essential for the outcome. We're not paid on tech, we're paid on outcome.
It's so interesting to think about. Is that really the key for a provider organization to shift their mindset? Or what challenges do you see from healthcare organizations as they try to align their IT infrastructure with value-based care goals? And what can they do to overcome that barrier, which is we have some IT, but we want to do value-based care. Obviously working with Aledade is one option, but what other things do you see with the healthcare organization? Is it embracing the value-based care? Is it a mindset? Or what do you see that's needed to overcome that so that they can align their IT infrastructure with that problem?
Yeah, I think it's really important for groups not to kid themselves as to what their true financial incentives are. And I think one of the things that unfortunately happens a lot is you get a chief medical officer, a chief clinical officer, a chief strategy officer, a chief population health officer who gets all excited about value-based care, but they don't have the buy-in of the CFO. It doesn't actually make business sense for the hospital, say, to have fewer hospitalizations. And then you're going to run into trouble down the line, right? When push comes to shove, when it's time to prioritize, do we prioritize this or do we prioritize the clinical documentation improvement of sepsis, which makes us more money, right? Which one are you going to do? And you're always going to be in the back of the line, as it were. So I think it is around one, first, making sure you have financial alignment. And then, yes, how do we integrate this within our roadmap and our tech and our policy and our governance and our clinical? But it
Yeah.
starts with aligned financial incentives.
So tell us more about that. Like, how do you do that at Aledade? Like, where and what are the specific insights that Aledade's technology platform is able to surface for physicians, and talk about some of the results and outcomes, financial and clinical. I think they both matter, right? To your
Yeah.
point, when you're able to apply a true value-based care perspective and technology platform, what are some of those outcomes that you find?
So, when it comes to saving lives, John, and this is my favorite trick question, which shouldn't be a trick question to ask of healthcare executives is what would save the most lives? What part of healthcare, what part of medicine, which quality measure, which evidence-based practice would save the most lives in America if we took the average up to the level of the best institutions doing it?
Uh-huh.
The answer to that is blood pressure control.
Oh, wow.
Yeah. And we do it, I don't know, 65% of the time on average, which is crazy, right? We spend trillions of dollars on everything except we're controlling blood pressure, which we know how to do with $4 medications only
Mhm.
2/3 of the time. And so that's one of the places that we start. I was one of the people who started the Million Hearts campaign when I was at HHS, and last year we had 90 practices who were recognized as champions in
Wow.
in hypertension control by the American Heart Association. And our blood pressure control rates for our traditional Medicare population was 84%. Where I trained at Massachusetts General Hospital, it was 76%. Mayo Clinic, Cleveland Clinic, they're all in the mid 70s. And,
Mhm.
we don't have fancy academic medical centers for the most part. We have, community health centers in the Mississippi Delta and one doc practices in Central California and multi-specialty clinics in Ohio. And we're at 84%. Why? Because it makes sense to prioritize preventing strokes and heart attacks. And so that's, again, it's not rocket science, but it's taking it actually seriously. And then, um, having posters and workflows that say, call us first before you go to the ER, and then having good follow-up when people do go to the ER and having good information at the point of care. In terms of the outcomes, I mentioned blood pressure, but we're also really proud that we reduce hospitalizations and ER visits year over year over year, and that results in a 15% lower cost of care after 6 years. And you might say, well, just 15%. Well, for context, we spend 7.5% of the total cost of care on all cancer.
Hmm.
So this is like curing cancer twice. Using primary care. And how much do we spend on all primary care? About 5 to 6% of the cost of care. So getting 15% cost savings is, I think, really significant.
Yeah. Well, and I think, it's interesting because in some ways you're almost doing the low hanging fruit and there's so
Yeah,
much more that could be done, right?
totally. Totally. This is, when I mentioned I was at Brookings and we published a toolkit for physician-led ACOs. And what we're doing today, 12 years later, is just the same stuff, just doing it better and more tech-enabled.
Yeah. I worked with one company who was focused on value-based care, and part of their solution was just reaching out and saying, "Are you thinking of going to the ER?"
Mm.
Like such a stupid question, right? Like that's so simple. There's no tech really involved other than you're sending a text message, and they reduce readmissions just by saying, "Are you thinking about it?" To your point, they didn't know they could just go to their provider or they could intervene earlier. It's so fascinating to see how simple the solutions are. Once we start caring about whether they're
Yeah.
readmitted or not.
Once we start caring about whether they're readmitted or not.
Yeah,
Yeah.
that's powerful. Let's dive into that a bit more though, right? Because as you said, a lot of the AI vendors are pitching productivity gains and coding optimizations. And to be fair, if I'm a doctor, I want that productivity gain. There's no doubt, and that's beneficial and helpful. But why would you say that's kind of the wrong approach for value-based care, to just using AI to improve productivity and improve coding and how well you're able to bill and claims and all that?
I was talking to one of our docs, Dr. Christine Meyer, Pennsylvania, and she gave this remarkable statistic that before starting to work with Aledade, they were seeing 3.6 patients per hour per doc. And in a fee-for-service world, if your costs go up and your reimbursement stays flat, what do you have to do? You have to see more patients now. You need more productivity. You need more RVUs. You need to see more patients in less time. And if you have that complex 86-year-old, you're going to put them off. You're going to say, come back. I'm only going to do a little bit with you today. Come back next time. But you don't know if there's going to be a next time. You're going to say, oh, why don't I go send you to these 3 other specialists? Right? That's the incentive. That's what productivity is in a fee-for-service world. See more patients in less time. And that's not what doctors want, and that's not what patients want. They want more time. So in a value-based world, they're now seeing 2.5 patients an hour. They're having longer visits and they're making more money
Wow.
because they're getting a check for their shared savings that's more than what they were charging fee for service for that patient all year long.
Hmm.
So if productivity is patients seen per hour, what's the product? Is it
Hmm.
health? Or is the product, you know, billing codes?
Hmm. What's the pathway out for a doctor though, right? Because every doctor listening to this is going to be like, that sounds great. But I'm still getting, requests from whoever it is, right? My admin, my whatever, that I need to do something different. Like, so what do you see as the kind of that pathway to value-based care, especially for someone I think everyone's dipped their toe in value-based care at this point. But what's that pathway to that model that you just described?
I think you have to make a decision. Like you have to say, yeah, I'm going to do it. And when we've had thousands of practices work with us, and we've had probably tens of thousands of practices say, I don't want to do it now. But we talk to them the next year and the next year and the next year. And more often than not, then there becomes a time when they're ready. And I think practices have to do it when they're ready to make a change. And change is hard. But I think it's important then to work with a partner who can be trustworthy, whose incentives are aligned with yours, who's a true expert and knows what they're talking about. Because doc practices have had bad experiences
Mm,
with partners who didn't know what they were doing or took advantage of them or you know did the wrong thing from a regulatory point of view and so forth. So who you partner with, I think, is really important. But if you're taking risk on the total cost of care, and if you have a five doc practice, you don't have enough lives with any one payer to have an actuarially sound total cost of care contract. You have to join with other people. And then the question is, who do I want to join with?
mm,
Who not only brings the regulatory policy, legal contract, but also the technology.
interesting. I mentioned AI, and I'd love to hear your perspective on what you see happening with AI. What are some of the biggest opportunities as healthcare adopts more AI tools? I mean, I think that's inevitable. Yeah, it seems to me, but particularly for independent practices, what do you see as the biggest opportunities for them?
I'm super excited. I mean, I've been a kind of a healthcare tech skeptic in some ways that blockchain and like all these
Sure,
things are going to web 3.0 whatever is going to revolutionize. But we're seeing um the AI revolution um really almost replace software development or big chunks of software development in a way that I would not have thought possible.
that's interesting.
So I'm a big believer that AI is going to be a major, major inflection point in health tech, where things that used to be like 10 years of coding can now be done with an API call to a foundation model, and you get an answer. That's pretty damn good. So then the question is, what are the use cases for that? And yes, you can apply it to coding and billing. And I think that's the first place where we're seeing, for example, costs go up because now you have clinical documentation improvement where a whole bunch of stuff is getting, whether it's you call it upcoded or right coded, to like the maximum DRG or the maximum CPT or the maximum number of, items get added and let no claim go unclaimed. Um, so that's the first kind of fee for service maximization, and then the response from the payers is going to be their AI agents denying and prior auth battles. And like, is that really what we want to spend our innovation on? Or do we want to spend it on something where payers and providers can be aligned over with the patient as of like, how do we keep this person out of the hospital? How do we keep them healthy? And so I think, again, back to my insight about EHRs, is they're the means, not the end. And if you're living in a context of fee for service, you're going to use the tool, whether it's EHRs or AI, for billing and coding. And if you're living in an outcome-based medicine world, you'll use it to improve outcomes.
Hmm. It's interesting for me to ponder. I mean, we've been a little critical of EHRs and what they've accomplished or not accomplished. But I'm also struck that like Aledade needs the data from the EHR to be
Yes.
successful, right? Like, I mean,
Yeah.
so that foundation was
Yes.
still important. Is that how you
It
kind of
was.
view it?
It was.
Like it didn't
It was.
achieve what we wanted. It wasn't the panacea of value-based care and keeping someone healthy, but it is that foundation that
It is.
innovative companies like Aledade can build on. Is that kind of how you view it as well?
It is, yeah. And in times when I'm less critical of myself, I do acknowledge that the electronic health record adoption we did put in place is the foundation for having these platforms. And like you can't do value-based care with paper. I don't think you can. It's certainly not at
You
scale.
couldn't search through 10,000 paper charts to find the 10 patients
That's
that
right.
need to be
Exactly.
followed up with immediately.
Exactly. Right. Unless you have that magic wand.
As good
And
as
so
HIM professionals were.
yeah, and so I do think also when it comes to AI, right? The what we've learned is that the value of the data is not necessarily in training the models. These foundation models trained on all the internet are pretty good, but what you gain a lot of value from is bringing data gravity to inference. The more I can tell the model about this patient, the better answers we're going to get. So I absolutely agree that um, the technology we put in place um, is the predicate for a lot of these advances. Now, one thing that is interesting to think about, John, is how much of our time did we spend on structuring data as it went
Mhm.
into the EHR, right? Don't just describe the patient's smoking history. You got to click one of the following mutually, exclusive and cumulatively exhaustive set of, are they a former smoker, a never smoker, a current smoker? How many, right? You have to put it exactly in the right format. And now, like, couldn't you just store it all as unstructured text and structure it when you need it on the way out? So it's a really interesting thought experiment in terms of the leapfrog that large language models could potentially make. And we're spending a lot of money on scribes to take unstructured data and make it structured on the way in. But does it need to be structured, or can you actually structure it when you need it for what you need it?
Yeah. I'm fascinated to see where that goes. I heard someone say, and I forget the exact number, but it was directionally correct that there was like 35 ways to say take one tablet daily.
Yeah.
And you're like, that's
Yeah.
fascinating. But to your point, could the AI make up for that and
Yeah.
solve for some of those problems? It's going to be interesting to watch, right?
Exactly.
Yeah. Well, Farzad, I appreciate you taking time to sit down with us. I know you're a very busy man and much in demand, so I appreciate you sharing, the work you're doing at Aledade. We're always curious to see how you're combining the policy, the technology, good business practices, and then put the patient at the center to make sure that they're receiving the care. So I appreciate you telling us more about it and your experience and how you can help, especially independent practices. I think is a major focus for Aledade to improve that. So thanks so much. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting applications. Thanks, Farzad.
Thank you.